Thank you, esteemed chairpersons. It's a wonderful meeting, and I'll straight go to my topic. Uh, we are discussing what I consider one of the most important, contemporary, practical, clinical issue. That's regarding the metabolic memory. Now, you see, all that is meant from this slide is the very simple fact that time is everything. It only shows time in various spaces of the universe. It only shows that time is important. If it is important for life, it is more important for diabetics and for the diabetic physicians. I have a very small agenda, and I want to make one declaration in the very beginning that I'll be very simple. I will not go into the complexities because the messages, the simplest messages, the truth is absolutely simple. I have centered my talk around 5 points. We'll see what is the concept of metabolic memory. What does it mean? Number 2 is what are the evidences? What are the evidences in type 1 diabetes? What are the evidences from the type 2 diabetes? Is there any evidence from the early animal experiments to justify that metabolic memory does exist and the very, very important factor in diabetes prognosis? We'll examine very briefly what are the mechanism, how this metabolic memory gets imprinted into our mitochondria, how this metabolic memory functions to keep someone absolutely free from complications if there is early best control. We'll see the mechanism. Of course, everything has the clinical practical utility. We'll see what are the therapeutic implications of this metabolic memory, and we'll discuss few future prospects which I will rather not highlight because Professor Sarita Bajaj is here. He'll be discussing the other issues. So I'll stop at the therapeutic implications. This is one of the studies in the animals. I'd just like to draw your attention to the last line. It was shown that in the dogs, by giving insulin, the retinopathy may be preventable, but tends to resist arrest even in its incipient stage before more than the first few aneurysms have appeared. I took this because it is believed that retinopathy as apoptosis of the beta cell is inevitable. This slide which shows that in dogs, even the best form of treatment, for years they found that a few microaneurysms appeared in the first few years, and even in this incipient stage of diabetes mellitus, so-called incipient stage, and the others could be prevented, but this could not be prevented, meaning thereby that diabetes is a relentless disease and the complications are equally relentless. Therefore, it is important to institute early best metabolic control. Dear friends, the early good metabolic control is remembered by the target organs, and diabetes affects from head to toe, and the sweet disease keeps it sour company because of the target organ aiming. Now, poor glycemic control is equivalent to bad memory, and even though we establish improved glycemic control later on, the poor glycemia early on produces complication in spite of later good control. This idea was mooted in 2002 June and also throughout 2003, which is carried on for eternity. It is from the nephropathy studies in which showed in the DCCT continued as EDIC study, it showed that the people who were early good control had in the epidemiology of diabetes intervention complication EDIC study, they had less complication if they have early good metabolic control. I'll come to it in a minute. And therefore, we have two terms. When it is DCCT EDIC evidences, we call it metabolic memory. When it is UKPDS study in the type 2 diabetes mellitus, it is termed the legacy effect, the effect of your legacy, the legacy effect. Dear friends, the DCCT and EDIC, the glycemic control, you will find the DCCT closed at this time. The EDIC years is beyond 8 years, and you find the intensive arm and the conventional arm. You see, the conventional arm is on the higher side, and you will observe that if you come to the earliest evidence, as I told you, EDIC microalbuminuria, it was shown that if you compared those who had early on intensive control, but who later on had conventional control, those who were conventional control, but later on instituted good control. In contradistinction, those who were intensive in the very beginning and later on were giving conventional management, the microalbuminuria was much lower. I'll repeat again that if you have established early intensive control, then gone into a conventional control, the effect of the early control is evident in year 1, year 3 and 4, year 5 and 6, and year 8, meaning thereby the microalbuminuria was much lower in contradistinction to the early on conventional group who were giving the similar form of management. And not only in the microalbuminuria, if you look for the cumulative incidence of the microalbuminuria compared to intensive group, even at the every year of the follow-up, you find that the conventional group fared worse. With the same treatment later on, they had more of microalbuminuria. Same thing is shown in the retinopathy. You will find that in the conventional group compared to the intensive group in retinopathy, the effect was very apparent. The early good intensive control outweighed the early conventional control, even though at the end of it, both of them got the similar type of treatment. Therefore, it was also shown that whether it is relevant for the adolescents, because in one of the arms of this particular study, they found whether the metabolic memory in adolescents was as strong as in the adults. It was found that if they analyze the A1C information further, the adolescents started with a higher mean A1C level than the adults at the time of enrollment in both the intensive group and on the conventional group. It is 9.6 versus 9 and 9.5 versus 8.9. And it was shown that the A1C remained higher in both groups during the entire DCT period, 8.1 versus 7.2, 9.7 versus 8.9. It was only during the EDIC follow-up that the mean A1C between adolescents and adults, as well as between intensive and conventional group converged, meaning thereby in the adolescents, the A1C at the end of EDIC study were similar. Now, it was believed that time, published in the 2010 in Diabetes, that adolescents possibly had a little less sensitivity to the HbA1c delta, and it was found that in adults, the effect was much more found compared to the adolescents. You come to the EDIC neuropathy study. I'll draw to your attention to conclusion that the benefits of the former intensive insulin therapy persisted for 13 to 14 years after DCCT closeout, and provided that there is evidence for a durable effect of the prior intensive treatment on neuropathy. So we have got evidences for the nephropathy, evidences for the retinopathy, the evidence for the neuropathy where the early control was very beneficial. Come to EDIC hypertension. Now you see DCCT closed here. You took the EDIC years of 2 to 8 and compared those who had early intensive blood pressure control to those who had early conventional blood pressure control, and you will find that more or less in the early control group, the blood pressure remained much better than the conventional group. Therefore, not only the blood glucose HbA1c, also in the hypertension, the early control effects were well seen. Come to civic outcome, the cardiovascular outcome, which is most important for the metabolic memory, because the 75% of the diabetics have ultimate cardiovascular complications, and you will find that if you see the conventional treatment, intensive treatment, the CV outcome was much better. Those who was early on intensive treatment compared to the early on conventional treatment, the CV outcome was much better. This is about the type 1 DCCT. I'll come to the second part, the pre-final part of my presentation. What are the evidences in the type 2 diabetes in the UKPDS follow-up study? Now, this is the UKPDS follow-up study, the conventional therapy versus the intensive therapy and you will find that when they were followed up for the microvascular disease, the intensive arm definitely fared better compared to the conventional therapy. And when they're followed up for the MI, the conventional therapy worse than the intensive therapy, and even the termination of life as regards death, the intensive therapy was much better than the conventional therapy. If you go to the other side of it, we have got three studies, three mega studies, which all of you are aware. The ACCORD study, which was instituted a good aggressive metabolic control at the age beyond 55 up to 87 years of age. We have ADVANCE study, we have VADT study, which wanted to institute a very aggressive control at a very later age. They took up the patients who were already beyond many years of diabetes, and they were about 65 years or more. And as we know the results, that in all the three, the CV benefit, the cardiovascular benefit of the intensive control was not very evident. And you know what happened why the ACCORD study was stopped in the middle? The CV benefits of the intensive control were not evident. I'll come back to in a minute. The subjects were older subjects, 60 to 66 years of age. The diabetes was at least 10 years of duration, 8 to 11.2 years. And as you know, we cannot be ever sure about the duration of diabetes in type 2. It's a silent disease. So at least known diabetes was about 10 years. And the baseline HbA1c was between 7.5 to 9.4, it was 9.1. So meaning thereby that if the patients are older, if the diabetes is already existing for 10 years or more, and the higher baseline SBC is already 9, older subjects, the CV benefit do not accrue. So the contrary also has been shown to be equally true. Now, this is a very complex slide you might have seen in all the publications regarding metabolic memory. I have taken it from there, from the JCM, February 2009. This slide, I'll try to simplify, but this is the ultimate mechanism through which the metabolic memory operates. To make a long story short, it operates. One of the mechanisms is to the ROS, the oxidative stress. It gets imprinted to the mitochondrial DNA, and also there is a deleterious cycle leading to the metabolic memory, and this is mediated to the respiratory chain proteins which are glycated and the resultant respiratory protein alterations. Now this is also mediated apart from the ROS, which directly in communication with the advanced glycogen end products, it also communicates in producing the genetic mitochondrial changes, also in the epigenetic changes in endothelial dysfunction. It also produces vascular stress signaling and ultimately gives rise to diabetic complications. Now I'll just concentrate on the reactive oxygen species, the ROS, as a mediator of the cellular injury. Now it has been shown that if you reinstitute good metabolic control in diabetic rats and activate various other cascade of events, you will find that there is some benefit, but not the ultimate benefit. And it has been also shown that even the blood glucose changes. I like what Professor Santanam said, the previous chairman said, the previous discussions were very relevant to what we're discussing now. It was shown if a transient high glucose caused persistent epigenetic changes. I'm just showing a paper which is published in JEM, a very prized journal. A transient high glucose causes persistent epigenetic changes and also sometimes altered genetic expression. Can you believe it? Even transient during the subsequent normoglycemia, meaning thereby that glucose is bad and hyperglycemia is bad. The earlier that you can do, I mean something is beyond our control. We discussed clinical inertia, but something is beyond our action, which is before. We cannot do it. We cannot take life to preconception and pre-diabetes. So whatever we can do, if we institute this, is going to be beneficial. Now this epigenetic mechanism, I've just brought a cascade of events which is mechanism for producing it. It operates through the NPK kappa beta, subunit P65, to the MCP1, VCAM1, TNF alpha and COX2, and today the literature is flooded with various other epigenetic mechanisms which can produce diabetic vascular complication. effect which is directly a outcome of the hyperglycemia and the not controlling early on. Now, this persistence of memory produces mitochondrial protein alteration. It also produces epigenetic changes, and also the proteins, we have long life, long-lived protein, it produces the AGE modifications, and this contribute to the metabolic memory. Now, there are various ways of again proving it by the various agents supporting the AGE and the nephropathy, how their progression occurs because of advanced glycogen end products in the people who progressed, people who did not progress, meaning thereby that the AGE is very important. And I must tell you that I will stop here to say that, as you discussed some time back, and the speakers told that the good early diabetes control is important. It is not important that you should only bring it down by insulin. Oral drugs are equally good enough. I have shown one paper in which oral drugs also have produced similar results. So it is said, by hook or by crook, or by hook and crook, establish early good control for the sake of best results. Early aggressive therapy, whether whatever tools you use, is very, 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 very beneficial. Thank you very much.